Well, thank you very much to Jonathan and to JPS for the invitation to say a few words about the pediatric end of things, and thank you also to the stellar faculty that we have here. I noticed when the program came out that not only were we meeting at the Harvard Club, but there was a distinctly Boston flavor to the faculty, which brought me back to my initial contact with American medicine. I was 18 years old. My mother's first cousin ran a small hospital in western Massachusetts, and I went there for the summer to work as an orderly, and I got quite friendly with one of the surgeons there. And he said we would not be around next week because he was going off to a big important meeting. I said, "What do you mean by a big important meeting?" He said, "Well, lots of experts." And I was just off the boat and very anxious to find out what this magnificent world was all about. And I said, "What do you mean by an expert?" And he says, "It's a bunch of guys from Boston with slides." I find that I probably have to explain to half the people in the room what a slide was, which perhaps ages me more than it should. But many thanks to the guys from Boston with slides, and by that criteria, this has been a great meeting, and thank you very, very much. When I left Columbia in '92 and went to Chicago to do pediatrics, I presumed that my life would be an unending vista of 3 AVMs and 2 craniopharyngiomas a week with the occasional shunt. It didn't quite turn out that way, but pediatric neurovascular malformations are not exactly a public health problem. Even at the busiest of pediatric hospitals, you really only see about 3 or 4 AVMs a year. So the problem with that, or one of the issues that it brings up, is that the actual technical care of these children is, if anything, more difficult than it is for adult vascular disease. Because you see so few of them, it's very difficult to keep up the technical level that you need to take care of these children well. But one of the things I've also learned over the years is that there are very special considerations that one needs to consider taking care of children with neurovascular malformations, and that if you apply all the available technical skill, they can do very, very well over time. Now, behind every fetish is a foul-up. I was told that by Paul McCormick, one of my professors at Columbia. And this has become something of a bugbear of mine over the past few years. What exactly is a pediatric neurosurgeon? As I've done more and more adult stuff and done more and more adult vascular stuff too. So what exactly is pediatric neurosurgery? If you think about it, the patients that you see as pediatric neurosurgeon today will be alive in 10 or 15 or 20 years' time. Who's going to take care of them? So I think in much the same way as with the pediatric neurovascular problems, pediatrics in the future is going to need to take account of the fact that many of these children are surviving into adult years. And the resources, as I say, to treat these problems become scarcer. Adult hospitals don't usually have the expertise necessary to take care of these people, or at least many of these people, and pediatric hospitals don't want to see them after the age of 16. This is a 68-year-old lady I saw about a year ago when I came here first. She'd come in with what seemed like dementia and had this little abnormality in the thalamus. She had, it turns out she had a remote history of some surgery of some kind. She had some clips, and she hadn't had an MRI in many, many years. It turns out that she had this on MRI. We got the MRI because the plain film didn't show much in the way of metal. Back when she was about 9 years old, she was seen in Columbia where she had a medulloblastoma taken out. The story that she tells is that the big doctor was away, and she came in, but she looked so awful that the young doctor took her to the operating room and took out the tumor. And when the big doctor came back, he was very, very angry. Because she shouldn't have gone to the operating room, and she subsequently ended up being devastated for a couple of years. And then she had radiation therapy, and then she had radiation therapy again for recurrence, all the time being quite devastated, and her family felt that she was quite devastated, and she went on to keep a job till she was in her 60s and to have 3 kids who were all normal and very, but there wasn't something quite right about her. She seemed perfectly normal to me, except for this GBM, which she developed at age 68. But it just goes to show that you know, and anyone who's familiar with the history of the big doctors and little doctors at Columbia in the early 50s would worked out that the angry doctor was almost certainly Dr. Stuckey, and the not quite so angry doctor was Dr. Poole, whose name she did remember in follow-up, but I don't think that Dr. Stuckey being angry was exactly a red letter day or would have been remembered by anybody else. That apparently happened not infrequently. So is that a pediatric neurosurgery case? Certainly the fact that we were able to get an MRI on her owed something to the fact that we knew what sort of surgery she would have had back in the early 50s. Say the same week I saw this kid, the 16-year-old with a pineal region tumor, not a germinoma, it turned out, according to the CSF studies. We were able to take that out by sitting approach, supracerebellar infratentorial approach, which I learned at Columbia under Dr. Stein, and he's doing very well. He's throwing the pitch in apparently at Central Florida University's baseball game this weekend. I got a phone call from his father yesterday asking if it was okay if he could fly. The point being that pediatric neurosurgery patients tend to survive, and it's as well to plan for that. This is true actually also of large encephaloceles. I must say that the most poignant example of that for me was a child born with a huge encephalocele whose family were told that the baby would die initially, and the kid came to me at 6 months. I took off the encephalocele. Baby will die, I said. All the books said baby will die. And 4 years later, I bumped into the father at a pub watching a football game. Baby hadn't died, and we had made no arrangements for follow-up afterwards. And the family were livid with me and left to go back to the United Kingdom. His father was Scottish and his mother was Irish, and we never saw them again. But it was certainly a lesson for me in terms of the need for that follow-up is longer and stranger in pediatrics than it is in adult neurosurgery. So what are these special considerations? Cerebral blood flow is higher in babies than it is in adults. I mean, as a percentage of the cardiac output going to the head is always much higher. It's higher the younger you are, and really only starts to go down the older that you get. Collateral blood flow is better. And what that means, I think, is that, scare you. What that means, cerebral blood flow in middle-aged Irish males is compromised by a tourniquet placed around the neck, it seems. That was today's lab experiment. So cerebral blood flow is higher in babies. There's no question about that. It becomes less and less of cardiac output the older they get. And what that means essentially is that if you're operating on a child with an AVM under the age of 2, you really have to ask yourself whether you should be doing that at all. I've been involved in a number of disasters because the understanding of the fact that you would be making a huge change to the cerebral blood flow, to the overall cerebral dynamics and cardiac dynamics of the child have not been really thought about. Collateral blood flow is better. What that means is that you saw earlier very nice dissections of AVMs, and what you may have noticed is that you didn't really see much in the way of an AVM. I didn't realize AVM surgery could be bloody till I left Columbia, because Dr. Stein always stayed in the gliotic tissue, and we almost lost no blood doing AVMs. And in children that you can do that. A child can withstand loss of a little bit of brain very easily. However, does not really respond very well to getting too close to the AVM and causing bleeding, which causes all sorts of problems, both intraoperatively and in terms of the planning of the surgery. The surgery can't be staged if you do that. Aneurysms present unusually in children. I'll show you a few cases when we get to the aneurysm discussion, but the subarachnoid hemorrhage causing the subarachnoid hemorrhage and the aneurysm clipping that we see in adults just doesn't happen in children. Cavernous malformations present differently also. And as I said before, the follow-up is longer and stranger. This is a child that I saw when I was a resident. He presented to the emergency room at Columbia with in heart failure. So I think what this speaks to is the fact that the amount of blood flowing to the brain is significant from a cardiac point of view in small children. AVMs, Paul Arnold, who's my colleague at the University of Kansas, used to tell the residents that the secret to early retirement was one wife, one house, and the miracle of compound interest. And what that means, I think, is that the machine that pushes that statement also pushes AVM surgery. You don't have to believe necessarily that the percentage rate of rebleed is very high in a small child to believe that that child will die from the malformation rather than from something else. And consequently, I think they all need to be treated if they've bled at least once. Now, how to treat them? Radiosurgery is not a bad option, But surgery is not a bad option either. Neither of them are great options, but good surgery certainly trumps bad radiosurgery, and vice versa. There are some kids who have quite small lesions who the embolization people feel that they can get complete embolization of. I followed a number of them over the years. I think the important thing is is the follow-up that you give to those patients. You can't presume that just because you have a negative angiogram in terms of an early draining vein in a small child, that the deal is done, which more or less you can in an adult. The question of regrowth comes up. And when I was at Columbia, Abe Cater wrote a paper about a number of angiogram-negative AVMs which had been followed for a number of years, in whom the AVM had regrown, the presumption being that there was some form of something to do with AVMs in children that that meant that even though you had a complete removal, they would grow back. I don't know that one can necessarily say that completely. I think that possibly one could say that a negative angiogram in a child doesn't mean quite the same thing that a negative angiogram in an older person would. They may or may not regrow, but at least you need to follow up in the long term with these kids. One post-operative angio and then nothing else is not going to be adequate. You have to have at least a contrast CT. This is a young lady I saw in the past year here at South Nassau Hospital. She presented with an intraventricular hemorrhage. CT angio at South Nassau showed that she had an AVM in the left medial trigone of the lateral ventricle. We took her over to Winthrop and had great difficulty managing her ICP. So I did something that I developed when I was at Kansas, which is a bicoronal craniectomy, taking off a bicoronal flap, a huge bicoronal flap, and putting it into her belly. This operation, combined with an opening of the dura in a slit-like fashion on either side, like fish gills, takes away the problem of ICP completely. And she did very well. We were able to put the bone flap back. This is, again, a picture. It's a frightening and huge trephination, and if you're ever going to get the syndrome of trephination, you'll get it with this procedure. So we tend to put it back as quickly as we can. And they all improve once the bone flap goes on again. She woke up, or she was perfect about 2 or 3 weeks after the bleed, having been at death's door when she came to us. And she is someone who I sent for radiosurgery. Having trained at Columbia, there were not enough bad words to say about radiosurgery for AVMs when I was there, but I've learned over the years that, as I say, good radiosurgery is better than bad surgery every day of the week. And this is a young lady whose family in Hurricane Irene had lost half their house, and then Sandy lost the rest of it. So I did not think that they would be up for the possible ramifications of having a surgery where the risk would be all up front, and so sent them for radiosurgery. Still, I have more of a problem taking or sending small children for radiosurgery than I do older adults. I think one needs to be cognizant of the fact that we don't really know what the long-term effects of radiosurgery are going to be, even though they probably are fine. But I think in her instance, the social indications were more important. Just to speak a little bit about that particular approach to ICP problems in children, though I've used it in people as old as 78 years, this is a 4-year-old who was recently adopted from Ethiopia, who when I was in Kansas was sent over from the Children's Hospital because he had a subarachnoid hemorrhage. In fact, he turned out to have been abused and had this massive subdural, which we removed again with the same approach, a large bifrontal flap, and opening up the dura in a slit-like fashion so that there's no oozing. And the reason for this is that if you had done a large unilateral flap on that child, almost certainly the brain would have shifted out into the opening and it would have turned itself over, compressed itself, and strangulated. I have not seen this kid in a few years, but I spoke with the residents down in New Orleans, and apparently he's completely normal. This is his bone flap put back on again. Interesting technical note is that I've done this mostly in teenage boys. Teenage boys, as they recover from severe head injuries, go through a phase where they will pick at anything and everything. And you have to be very careful that they don't pick at their scabs and get infected, because that's happened on a couple of occasions over the past year. Cavernous malformations were the special considerations when it comes to pediatric patients. Dr. Friedlander's wonderful talk on cavernous malformations in the brainstem, that's where you usually get life-threatening hemorrhages from the cavernous malformations, but in children, you can get huge cavernous malformations supratentorially, which can cause life-threatening hemorrhages also. Usually those large hemorrhages are associated with some inflammation pathologically around the cavernous malformation itself. More of them are familial than initially appear to be so, and I'll come to that later. You should treat all of the posterior fossa if possible. Now, perhaps tractography will change that, but historically and personally, for me, that has always meant coming to the surface. And you should treat symptomatic and accessible supratentorial lesions. This is a little girl. When I was a fellow in 1992, she came in diagnosed with having a brain tumor to Children's Memorial Hospital in Chicago, and she had this this lump here, and it was getting worse in front of our eyes, and nobody wanted to do anything with her. So I said, well, we should at least take her to the operating room, try and take out whatever it is, feeling that it was probably a cavernous malformation. And as Dr. Friedlander so nicely showed, we did a subtemporal approach and cut the tentorium, removed the cavernous malformation in its entirety, and this is post-operatively. That approach is wonderful for anything in the brainstem that pokes at the comes to the pia and is at or above the level of the fifth nerve. She was perfectly normal after this, having been moribund before we took her to the operating room. She became a ballerina. This is 20 years ago, remember, and the day when she was about 9, she would come in every year and would be normal, and couldn't understand why I would make a big fuss over the fact that she was normal. And then her mother said, well, because she's normal, do we really need to see her? Do we really need to see you ever again? Could we just leave clinic and never see you again? My heart was broken, because I said to myself, and how will I ever feel good about myself if all the patients who do well don't come back and see me? But they left, but they didn't leave forever. Because about 3 or 4 years ago, I got a phone call that her brother had been diagnosed as having a cavernous malformation in his temporal lobe, and did I know anyone out in Los Angeles who could take that out for him? So I think the point that I made earlier, the cavernous malformations tend to be more familial than we give them credence for. As Dr. Scott said, that these kids will do very well. I don't think I've ever seen a brainstem cavernous malformation in a child that I wouldn't go after if it came to the peel surface, unless it was completely impossible to take it out. But I mean, coming to the peel surface is the absolute sine qua non for me. I've taken a few out of the floor of the fourth ventricle. They all vomit for at least a month afterwards, but they do get better. If they don't come to the surface of the fourth ventricle, I don't touch them at all. But the ones that do at least present at the surface, I've always gone after. So aneurysms, as I said before, they rarely present as they do in adults. They're more likely to present with a subdural, which you go in after and then discover you have massive arterial bleeding at the bottom of it. Waxing and waning neurostatus, especially mycotic aneurysms, giant aneurysms, these are almost all huge and very difficult to take care of. And the posterior fossa, which are technically very demanding because the posterior fossa in a child is tiny. That being said, however, they have much more forgiving vasculature, so you can take major arteries sometimes and not have problems. This is, again, about a 9-year-old who came in with a brain tumor when I was about 1 or 2 years into my career at Children's in Chicago. When I saw him, I saw that he had a huge pica aneurysm rather than a brain tumor, so we took him to the operating room and clipped him, thinking that everything had gone fine. We'd taken his pica, never turned a hair. Pica was gone completely, had no sequelae from it whatsoever. And this is, again, I'd lost touch with him many, many years ago, and a few years ago I got this picture. This is his white coat ceremony from the University of Indiana. He became a doctor. So pediatric, this is a baby who'd been abused, came in with this large basilar tip aneurysm, which we were able to clip, and I'm sure that we got some nasty perforators when we clipped that, but the child did very well, again, because the vasculature is very forgiving. So the takeaway message is that you have to realize that there's more blood flow, more of the blood flow going to the brain. What you do has more implications in terms of the entire vascular system of the child. But once you've committed to doing something, and most of the cases that will present you will need to do something, then the brain itself, the vasculature, will be more forgiving. Vein of Galen malformations are essentially an AVM of the galenic system that is just drained into the vein of Galen. I still know people who maintain that this is a surgical disease, despite the fact that not only have they never got a patient off the table alive, but no one that they know has ever got a patient off the table alive. which one can only admire as a perseverance in the face of adversity. But there's no question that these are endovascular treatment alone. And much the same thing I would say about vein of Galen malformations, whether they present as cardiac failure in younger children or as causes of hydrocephalus, as this one did in older children. The treatment for these things is entirely endovascular. And I think the same restrictions, I would say that if you're operating on an AVM in a child under the age of 2, you should ask yourself, should you really be doing it or not, is something that one should bear in mind. So, I don't know if anyone recognizes, this is the late great Sevi Ballesteros, who died of a GBM a couple of years ago. Even the great ones get into the long weeds. I remember Roberto Hiros giving, when I was a medical student at MGH, giving a talk about a huge AVM that he'd operated on, and he kind of lost the run of himself in a way. He was talking about these little corkscrew blood vessels at the bottom of and this was over in the shrine when I think it was the case records of the MGH thing that he was doing, going on and on and on about these little corkscrew blood vessels at the bottom of the bed and how of the bed of the AVM, and how that would just drive you crazy. And you're there, it's 10 o'clock at night and everyone else has left the hospital, and all you want is for the patient to die so you can go home. And I never really understood that until about 20 years later, when I found myself in exactly the same position, thinking either one of us is going to die. I'm not sure that I know which one it is. But I think that my experience with neurovascular malformations in children would suggest that they are technically difficult to take care of. They are, however, as most things in pediatrics, are quite forgiving for technical mistakes that are made. The children end up doing relatively well if you can get them by the initial problem, and they are among the most gratifying of the cases I've ever taken care of. Thank you.